Thank you. Well, good afternoon, everyone, and welcome to Trust for America's Health's Age-Friendly Public Health Systems September training. We're really happy you're joining us today to learn more about how the public health sector can support older adult health and well-being. My name is Megan Wolf. I'm joined today by my colleague, Dr. Karan Phillips. And our movement, the AFPHS movement, would not be possible without the generous support from and partnership with the John A. Hartford Foundation. So we're very grateful to our partners there. Next slide, please. We ask that you all please keep your devices muted during the presentation so we can avoid any background noise and interruptions, but we do ask that you please add any questions, drop any questions into the chat throughout the presentation today, and we'll have some time at the end for discussion. Next slide. All of our trainings are recorded and the slide deck will be shared with all of you who have registered after the training. So if you're using an AI note-taking tool, we would appreciate if you would let us know by commenting in the chat before our speaker begins. You must be present in the training with the AI note-taking tool, and any notes generated from the AI tool can only be used for personal use. Next slide. Your feedback is really important to us, and so we're asking that everyone please take a moment to complete the anonymous feedback survey that will pop up on your screen at the end of today's training. Your insights will be shared with our evaluation partners at the New York Academy of Medicine and will really help us to enhance future trainings. Next slide. So as most of you know, Trust for America's Health, or TIFA, as we're commonly known, is a public health policy research and advocacy organization dedicated to optimal health for every person and community. TIFA produces several reports annually, and today we just released our 2025 funding report, which I'm going to preview for you in just a moment. We also publish periodic briefs related to our AFPHS work, and we have one coming out on September 30th on caregiving and how the public health sector can support family caregivers. So we will make sure that you have links to that. If you subscribe to our newsletter, you'll see it, a link to that in the newsletter. Next slide, please. So just a quick preview of our funding report that is called Public Health Infrastructure in Crisis. And you can see there the web address, tifa.org/reports. But if you go to tifa.org, it'll just pop up on the main screen there. Next slide. So we decided to go a slightly different direction this time for our reports. We usually report on what the actual budget is, but this year we have taken a slightly different approach. The report is really focused on the president's proposed budget and the related implications of the president's proposed budget with regard to workforce reductions, the hiring freezes, the RIFs, the layoffs, and particularly the disruptions in the loss of expertise at CDC, but really across all agencies at HHS. And I think Alison is going to address some of that today. Also, what the report addresses is what happened in the FY 2025 budget and the funding cuts, the delays in some of the funding outlays that should be going out that are a little bit jammed up at this point. Also, the proposed reorganization of HHS, the creation of the Administration for a Healthy America, and the elimination of the agencies that are very, very important to all of us. And then a deep dive into what the proposed budget actually looks like. Next slide, please. So just to give you a sense of what we cover with regard to major cuts, programs that address chronic disease, the chronic disease prevention budget has been nearly eliminated. Nutrition, tobacco, cancer, heart disease, healthy schools, all of these will be cut in the president's budget. The prevention fund, which is very important to public health, is usually $1 billion annually. It's been eliminated. And that means a loss of support for immunizations, labs, workforce, and so forth. Environmental health, preparedness, data systems. The impact is not just, kind of this theoretical impact. This is real. This is a real loss and real impact. States and localities, as you all know in the field, you are already experiencing the impact of the cuts and even the proposed cuts. You're experiencing the impact of the chaos and the uncertainty. Next slide, please. So TIFA really focuses on moving forward with recommendations and lobbying. And oh, I guess I didn't have the slide. I thought I had a slide on recommendations, but please take a look at the report and the recommendations. Most of them are focused on our federal advocacy efforts, but we really commend the whole report to you. Hopefully it will be not just a drastic experience for you to read, but really informative, and let you know that we at TIFA are here to support you and doing everything that we can. Okay, now you can go to the next slide and we will introduce our speaker, Alison Barkoff. We are so pleased that Alison is here to share her expertise with us. Alison is currently the Harold and Jane Hirsh Associate Professor of Health Law and Policy at the Milken Institute School of Public Health at George Washington University, but we all know her best from her leadership as acting administrator at ACL and as the Assistant Secretary for Aging from January 2021 to October of 2024. Alison has also been featured in the spring edition of the Generations Journal through the American Society on Aging that Karan and I helped to guest edit, that was on the age-friendly ecosystem, and Alison contributed her great expertise to that as well. And today, Alison will be discussing the intersections between ageism and ableism and the importance of including the disability community in age-friendly efforts. So welcome, Alison. We're so happy you're here. Thank you.
Great. Thank you so much. It's really a privilege to be here today. And thank you to TIFA for all of your incredible work on elevating aging and partnerships with public health. And today I'm going to really talk about some of the bridging aging and disability. And I think that's one thing that is a real strength of the Administration for Community Living, which for people who may not be familiar with it, it has been. It still is today. We'll see you tomorrow as things get implemented, but it is an agency that was created about 13 years ago to bring together programs and policy around aging and disability focused on community living. And as Megan mentioned, I had the privilege of leading the Administration for Community Living during the pandemic, actually. And a lot of what I'm going to share today really came out of what I saw, and I think many of us saw, is the real need for partnerships and expertise in public health systems around aging and disability. Next slide. So I probably, if you showed up to this and you are part of the age-friendly systems, I probably don't have to convince you why partnerships with aging and disability are so important, but I just want to say out loud a few things. I mean, number one, older adults and people with disabilities, and I'll show you some statistics, are a really significant proportion of our population, and it is a group of people that is hugely growing. So having that expertise is really key. A fundamental piece of public health is around focusing on health disparities. And I'm going to talk with you a little bit about the significant health disparities that both older adults and disabled people face. There are significant access barriers when we think about how to respond to emergencies. And I think that became incredibly visible during the COVID pandemic. And then one thing Megan didn't mention is I am a longtime civil rights lawyer. I live both in the legal and policy worlds, and there are a lot of civil rights laws that relate to both older adults and people with disabilities that both create legal obligations. But I hope by the time you hear the end of my presentation, it's really about our shared values and things that we should be doing. And aging and disability partners can really help you in meeting those obligations. Next slide. Next slide. So I'll start with just a little bit of background on aging and disability. Now, one thing that is so astounding is how significant the population of older adults is growing. I mean, that is why the work that TIFA is doing in the aging space is so important. 11,000 people literally every single day turning 65. In many places across the country, we already have more older adults than children under 18. And if you look at the statistics here, by 2030, across the entire country, we are going to have more older adults than children. And it is the hugest growing population. So if nothing else, if you are in public health and you see this slide, I hope it makes you feel like I really, really need to have some aging expertise. Next slide. I'm going to talk a little bit about the common disparities across both older adults and people with disabilities. I so value the partnership in public health and how you all are really focused on a population level of underserved communities and addressing some of these health disparities. Very significant percentage of older adults are racial and ethnic minorities, and that is going to continue to be growing. We have many, many older adults who are low income, a very significant percentage, and again, that continuing to grow. ACL every year does this kind of state of older adults, and the percentage of older adults who have chronic health conditions often, which is natural in some ways as people age, but also for people who may come from underserved communities have even higher rates than other people. When I talk about this intersection of aging and disability, while many older adults might not identify that way, over a third of people over 60 have disabilities. Think of mobility limitations, vision, hearing, cognitive, and as people age, more acquired disabilities. I'm not going to spend tons of time talking about housing instability, but that is a huge issue with older adults being the fastest growing population of people who are experiencing homelessness. And so all of these are reasons why, again, as you're thinking from a population standpoint, older adults absolutely need to be on your radar. Next slide. So I'm going to focus on disability, and maybe people have a little bit less expertise there. And it is a really, really broad and diverse group of people. The definition that most of us use is the definition in civil rights laws that talk about a physical or mental impairment that substantially limits one or more major life activities. And that is 1 in 4 adults in the United States, a huge population. So again, I hope when you see these statistics, it makes you think, this is really a population I need to be paying attention to. And many disabled people face, and I'm going to talk more about this, stereotypes about their capacities, their value, a lot of stigma, and a lot of barriers. And again, these barriers can be very common across older adults and people with disabilities. Next slide. Just to dig in a little more about the diversity of disability, I suspect most people, when they think about disability, may think of someone in a wheelchair with a physical disability, but there's a whole range of disabilities, some that are visible and some that are not visible. And, visible disabilities could include physical disabilities, some types of developmental disabilities like cerebral palsy, or some types of intellectual disabilities like Down syndrome. But there's a lot of invisible disabilities or non-apparent. You might not be able to tell that someone has a vision or hearing disability or a psychiatric disability or some cognitive disabilities or even some developmental disabilities like autism. So I think understanding the breadth of what we talk about when we talk about disability is really important. And then again, as a group of people who are really focused on equity and health disparities, disability is actually more common, and there are higher percentages of disabled people among a lot of underrepresented communities, whether we're talking about Black, Hispanic, American Indian, people who are older, LGBTQ, low income, and living in rural communities. So I think, any of the populations that you work with are going to have older adults and people with disabilities in them. Next slide. So I want to kind of talk about the long history of discrimination and barriers that people with disabilities face. And again, when I think about kind of healthcare writ large, Oftentimes we talk about how hard it is for people to access doctors and access healthcare. I often say disabled people literally can't get in the door. They literally can't get on the table when we think about inaccessible medical equipment or communication barriers. Think if you are deaf or hard of hearing and you're trying to use telehealth. Really, the ableism and lack of knowledge by healthcare professionals is pretty profound. And we often see, and it became very visible, both cross aging and disability, the stereotypes that many medical professionals have and bias about what the quality of life of disabled people are. And we saw many hospitals putting in place crisis standards of care that literally said to disabled people, go to the back of the line or you're not even eligible to get in the line for life-saving equipment. And for much of the history of disability, many people with disabilities were segregated in institutions, not part of their own communities. I'm a sibling. My brother is in his mid-40s. And when my brother was born, everyone with intellectual disabilities like him were in state institutions. The world has changed a lot, but it has not been that long, and we still have a lot of segregation. This health affairs study, I think, just really emphasizes the fact that we have a healthcare system who has a belief that people with disabilities have a lower quality of life than people with disabilities themselves view it. Very few medical professionals feel confident in their ability to work with patients with disabilities. And many, many do not want to welcome patients with disabilities into their practice. So again, when we think about chronic disease and lack of access, we have just all these different types of barriers that disabled people face, including older adults who are people with disabilities. Next slide. Again, just like looking at the disparities, it has been an area that has not been very visible until the last several years. There's not enough data collection on disability, and in many places where there had been much more age-based data collection. And we really built a case over the last several years about the disparities experienced by people with disabilities. More chronic disease, less access to preventative health care, shorter life expectancies, very, very high rates of poverty, housing instability, and homelessness. And because of a lot of advocacy, it was a real privilege to work with the National Institutes of Health when I was at ACL. And in September of 2023, people with disabilities were officially designated as a health disparities population. Again, as public health officials, I think that is another reason to really lean in on the importance of understanding and focusing on disability. Next slide. So this is where I really live a lot of my advocacy, and I really do believe that we are stronger when we work together. And again, as I mentioned, I think one of the real successes of ACL, and it has really spread out into the advocacy community, into state and local government, is the fact that there are so many commonalities across aging and disability. And again, as you are involved in healthy aging initiatives and age-friendly initiatives, I would really encourage you, and feel free to read my article and making the case about why it's important. But these populations have so many overlaps between who they are and their priorities that I don't think you can do age-friendly well without really thinking about age and disability together. So as I mentioned, older adults are actually, many are people with disabilities. They may not identify with that term, but they are actually the largest subpopulation of disabled people. And we have many people who age with their disabilities into becoming an older adult. Again, the life expectancy of people with disabilities has really grown over time. And then, as I mentioned, many people acquire disabilities as they age. This intersection between ageism and ableism, and I know through the work with TIFA, you've done a lot in thinking about reframing aging and thinking about people's capacities and how do we work to be inclusive. But as I mentioned, that discrimination and stereotypes and bias really cuts across both older adults and people with disabilities. And as I'm going to talk about in more detail, disability rights laws are really important tools to fight both ageism and ableism in that intersection. There are so many common priorities, whether it's accessing community services and supports, caregiving, affordable housing, accessible transportation. And again, I think the advocacy is so much stronger when the communities work together. And then I'm going to talk next about some of these common access barriers and really lean in on some of the places where I think public health really has some opportunities to address those access barriers. Next slide. Okay, so I am now going to jump into those barriers and how that really impacts public health. Next slide. So there are a lot of different types of barriers. I think when we take a step backwards, people, I think often, as I said, think about physical disabilities, and the physical barriers are incredibly significant. I mean, fortunately, we do have civil rights laws that have started to chip away at and build accessibility, at least of public places. But we still think of so many places where you might go. And oftentimes here, well, there's just one step. Well, guess what? If you're in a wheelchair, it doesn't matter if there's one step or 20 steps. It's inaccessible to get in the door. So those physical barriers are real. We talked about those attitudinal barriers and the perceptions of people with disabilities and older adults. I think that is really at the core of ageism and ableism. Communication barriers, we're going to talk a little bit about that, but think of someone who might be deaf or hard of hearing and can't access information, and you don't have an ASL interpreter as people are sharing information. We saw that kind of thing. Someone with a cognitive disability who can't understand incredibly complex language and the importance of things like plain language information. The economic barriers are incredibly real, particularly with the just huge disproportionate part of both populations who live in poverty and for whom things that maybe other people may think are not a lot of funding, not a lot of cost, become really big economic barriers. And then we just have these long-standing systemic barriers that I think cut across all of these things that both populations face. Next slide. So I want to talk about one place where I think, this has been pre-COVID the place where there was really some visibility. I hope we continue to think about all types of emergencies and disasters, but just put your mind into, when you across all the different states have experienced some type of natural disaster, whether it's a hurricane or a tornado or some kind of storm. I mean, the first thing that I will say is there is always this misperception that most older adults and people with disabilities are in facilities. And there is probably very good visibility, or at least better visibility and tracking. Okay, we know how to find a nursing home and call a nursing home and say, what do you need? But the vast, vast, vast majority of older adults and people with disabilities, well north of 85% or 90%, are actually in their own homes and in their own communities. And that makes it a place where really people and public health systems may not have the same type of visibility. But we have to think about the fact that people may have trouble evacuating. They may not have access to transportation. Even if they can evacuate, if a shelter is inaccessible, then someone's not going to be able to use it. And as I talked about, the inaccessibility of getting information can be a really big barrier. Many people to live in their own homes and communities may have in-home supports, home care coming into their home, durable medical equipment they use. And those are things that immediately in disasters become impacted. 4 times more likely to die. And again, we have seen this again and again and again across disasters. As I mentioned here, the National Council on Disability, really starting with Katrina, has done a series of reports. And, it is so predictable what happens every time because People with disabilities and older adults are too often overlooked in disaster planning, in response, and in recovery. Although, as I'm going to talk about, that is starting to change. So again, this is one reason why these populations have to be part of front of mind for you in your work. Next slide. As I mentioned, I had the privilege of leading the Administration for Community Living during the COVID-19 pandemic. And when I was asked to join ACL, I just felt this incredible weight on my shoulders of wanting to walk in, and I knew I needed to be the voice. People with disabilities and older adults very early in the pandemic were completely invisible in federal policies, despite being among the highest risk populations, the people who had the most severe disease, the most severe death. And really, in that circumstance, we again saw these access barriers, challenging in getting vaccines. They might have been on the list of people who are the highest priority, but if they didn't have an accessible vaccine site, you had to register through a website that was inaccessible, there was no transportation, that was a huge barrier. As I mentioned, we saw discriminatory denials of life-saving treatment like ventilators. Many people immediately lost critical services when the shutdown happened, and it really led to them being isolated in their own homes without supports, leading to very high risk of being placed in nursing homes, the very place where deaths were among the highest. And what I saw, and this is not a criticism, this is really just was a reality, is public health systems did not have a lot of expertise and connection to the aging and disability networks. And so much of my time at ACL was really about building those bridges and helping public health understand you don't need to be the expert, you need to be connected with the networks who are the experts, and that helps you be a force multiplier. Next slide. So the pandemic did create a lot of momentum, and I'm going to talk about three different things. One is it really did create this urgency to update legal requirements in the disability rights laws that hadn't been updated in almost 50 years to really modernize and talk about the many barriers that people with disabilities, including older adults who are disabled, face. There really has been an increased focus in the last several years on inclusive emergency planning, response, and recovery, and I think that is in part from the COVID pandemic. And then for anyone who has spent any time with me, it is always about partnerships, 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 and then partnerships again. And COVID did create that opportunity to really start building relationships between public health systems and the aging and disability networks. Next slide. So let me talk a little bit about what these legal obligations are. And like I said, I hope that as you hear about these and learn about them, they really feel like the right thing to do and what really aligns with public health's values in addressing health disparities and advancing equity. Next slide. So there's three major civil rights laws that apply when we're talking about disability rights. The first is Section 504 of the Rehabilitation Act, which prohibits discrimination on the basis of disability for all recipients of federal funding. So think about, that's y'all, you get federal funding from HHS, but that is any doctor's office or medical facility that gets Medicaid or Medicare funding, that's clinical research, that's all the different housing and homelessness providers that may get funding from HUD, it's transportation that may get funding from the Department of Transportation. And each of the federal agencies have their own Section 504 regulations. The second that people are probably most familiar with is the Americans with Disabilities Act. And it prohibits disability discrimination by both public entities. So think about state and local government. Again, that's you. You're covered. Many of these laws are very overlapping. And it also covers places of public accommodation. Think about shopping malls, restaurants, those kinds of things. And that's enforced by the US Department of Justice. And then again, in the healthcare space, the Affordable Care Act has its own discrimination provisions called Section 1557. It really comes from a very broad intersectional lens, pulling in all the different civil rights laws and prohibiting discrimination in health programs on the basis of race, ethnicity, sex, age, and disability. And that's enforced by HHS's Office for Civil Rights. Next slide. So I'm going to just briefly talk about the update to the Section 504 regulations. It was a very, very big deal. And as I said, the breadth of this is so big. HHS funds so many parts of our healthcare and public health system. And I would say it was really driven, there was a drumbeat that had been happening maybe over the last decade around, how much the healthcare system has changed over the last 40 years. I mean, think of the role technology plays. None of that existed, of course, 40 years ago. The more that we saw about disability and health disparities, people felt more and more that it was important to really address some of those. But more than anything, I think the insidious discrimination that people saw in the COVID pandemic made this really a top priority of the disability community. At least when I was at HHS, public comment and feeling like I felt like this rule was not our rule. This was the community's rule. We needed to respond to what people with lived experience were experiencing. We, of course, needed to hear from all types of stakeholders about how to put in place rules that were fair and doable while really address some of this discrimination. And there was more than 5,000 stakeholder comments in the rulemaking process, and we responded to each and every one of them. And the final rule was issued in May of 2024, and the majority of provisions went into effect in July of 2024. So this is now the law. I know there is a lot happening with deregulatory potential efforts at the US Department of Health and Human Services, but this is the law at this point. Next slide. So I just want to touch on a couple things that I think are really important in these regulations. And many, as someone who's done a lot of civil rights enforcement, people had been working from this old set of regulations from the statute and had been doing work in many of these spaces, but we all felt like having more specificity so covered entities understood better their obligations, people better understood their rights, was really important. And I think the thing that I am most proud of, that I feel like really is probably the biggest thing, and I've been doing disability rights work for over 30 years. I feel like this is maybe one of the biggest things that I've had a chance to do to really address health disparities and advance health equity for people with disabilities, is these medical treatment provisions that are very clear that it is discrimination to make treatment decisions that are based on bias or stereotypes or judgment that disabled people are a burden or that their lives are worth less. I think it sends an incredibly strong message, and it applies to all types of medical treatment, life-sustaining treatment, crisis standards of care, organ transplantation, clinical research. And I will just say, most people don't read the preamble to a rule and find it like, heart-wrenching. When we sent this up through clearance, I got a call from the secretary's office, and the counselor said to me, I read this and I cried. Is this really what people experience? And the answer is yes, this is really what people experience. And I'd encourage you to really look at that. It is very driven by people's experience with our healthcare system. Next slide. As I mentioned, accessibility is a huge, huge part, and it's really many of the barriers that disabled people face. For the first time, it set requirements around accessible medical equipment. Think about mammogram machines, being able to be weighed, being able to get on an exam table. And it set a specific number within 2 years and aligned this with ADA rules that came out around the same time for public entities. Websites and kiosks, just think about how much of our daily life is part of websites, how much part of healthcare is now part of kiosks. I can't think of one time I haven't gone into a doctor's office and had that. And again, setting accessibility standards for websites and mobile apps, and again, aligning that with ADA rules. Physical accessibility and making clear that, again, this was about these regulations hadn't even been updated since the ADA was passed in 1990. So a lot of this was about making sure that entities that are covered by multiple civil rights laws had the same requirements across all of them. Next slide. Communication is really important, and I hope it's something that you think about a lot in the public health world. And like the ADA standards, it requires effective communication. That is things like sign language, captions, alternative formats, plain language. And the regulations talk about primary consideration is given to the requests of disabled people. Now, there are lots of rules around, when things might cost too much. But again, these are things you should be doing as a matter of course in a lot of the work that you're doing. Next slide. And then there are things like thinking about the policies that you have, and they may not be intentionally keeping disabled people out, but oftentimes it might screen people with disabilities from participating in programs. So it's a really important thing when someone says, I need some changes to the way that you're operating a program, that if it is reasonable and it's not an undue burden, we need to think of ways to increase access to people with disabilities. Next slide. And then finally, a really important piece is that both Section 504 and the ADA have an integration mandate that requires covered entities to provide services in the most integrated setting appropriate to an individual's needs. And the Supreme Court held in 1999 in a really important decision called Olmstead versus LC that it is discrimination to unjustifiably institutionalize or segregate people with disabilities of all ages. And in interpreting this law, it applies to all types of services, whether we're talking about residential, day, educational, as well as disaster and emergency services. Next slide. So just a few things to consider is that, they are legal requirements. So I want to be clear about that, but I think they really are steps that are necessary to advance health equity and address and meet the needs of these at-risk populations. And as I'm going to talk about again and again and again, there are resources, experts, and partners who can help you with implementing these and best practices. Next slide. Let me just briefly talk about inclusive emergency planning. Next slide. And I'll just mention that ASO has put together some key principles, and I'd really encourage you to look at those. I think they're really excellent in really operationalizing what do we mean. Equal access. That means that disabled people should be able to access the same programs as the general population. Physical accessibility, effective communication. Inclusion means that people have the right to participate in and benefit from all of these emergency programs, services, and activities. Integration means that we're not creating separate, segregated programs for people with disabilities. Equal access may require changing some of your modifications. We shouldn't be charging people with disabilities to be able to access the programs. And with all people, disabled people should have self-determination in deciding which programs they do and don't participate in. Next slide. There have been a couple ways that I think disability has really been, and aging have been embedded into emergency planning. You know, at the federal level, at least speaking for when I last left, there were a lot of federal agencies that were really working together and trying to think about, let's use all the tools in our toolbox. FEMA has had an Office of Disability Integration and Coordination. ACL brings its expertise around aging and disability and its networks. ASPR really appreciated the partnership, CDC, National Council on Disability. There's been a lot of federal legislation around disaster planning that started to really highlight the need to think about aging and disability, and everything from the pandemic, all hazards preparedness act, reauthorization, or the Ready for Disasters Act. And then there's been a lot of state and local planning efforts. More and more we have seen with intentionality, bringing to the table the disability and aging communities. Next slide. I want to end by talking about partnerships between public health and the aging and disability networks, because I think it is just so key. And there's work that we did that I hope we do not forget, the lessons that we learned, the relationships that we built in COVID. And I want to end with my plea of really keeping those up. So next slide. So just to explain who the Aging Network is, in case you're not familiar, the Administration for Community Living funds an entire aging network, going first through state units on aging, and then separately each of the tribes have their own tribal organization. So that's the state entity that is funded directly by ACL. Then the state units fund what are called area agencies on aging, and they are assigned a geographic area. And again, that's probably who your right partner is going to be if you are at a local level, or if you are a state public health agency, it would probably be your state unit on aging. And then from there, they have just tentacles that work with more than 2,100 service providers, 80,000 volunteers. This reaches 1 in 6 older adults in a whole range of services. Think about things like senior nutrition and Meals on Wheels, transportation, in-home supports, case management, caregiver supports, respite, supporting the rights of people who are in nursing homes and assisted living through ombudsmen. These are just incredible partners to help you reach the many, 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 many millions of older adults who are in their own homes and in their own communities. Next slide. Similarly, ACL funds a set of disability networks. There's not a state agency that they go through in the same way. They fund directly the community-based organizations. So there is a set in every single state of developmental disabilities networks, the protection and advocacy systems that do legal advocacy, state councils on developmental disabilities, and then university centers for excellence in developmental disabilities. Every single state has those DD partners. In the independent living networks, there's both statewide councils in every single state, and then think of kind of the version of a AAA, the area agencies on aging, or the centers on independent living, who provide direct services to millions of people with disabilities across the country. And then there's a whole set of other disability networks, aging and disability resource centers. Think about information and referral, the state assistive technology programs, traumatic brain injury programs, limb loss and paralysis resource centers. Next slide. So how to find your aging and disability network partners. There are links here. You can go directly to ACL. We have long had, or ACL has long had, this website and resource called the Elder Care Locator, where you can put in your address and find your aging networks. And with funding through COVID, we were actually able to launch a similar line for the disability networks called Dial. Next slide. I want to just give 2 examples of state and local partnerships that I think were really effective and really important. And I hope maybe some of you might have even experienced some of it. So when we were thinking about priorities in terms of reaching people with COVID vaccines and boosters initially in the pandemic, and then really broader vaccine access for particularly high-risk populations like older adults and people with disabilities. CDC and ACL launched a partnership between local public health agencies and the aging and disability networks. Again, there is a real trusted voice from the aging and disability networks and a real expertise about how to think about accessible vaccine sites. People who are doing home delivered meals are like a natural place to partner, for example, with someone who might be doing in-home vaccinations. And again, when we're thinking about addressing barriers like transportation, working with the actual networks that can provide that was really, really important. Next slide. It was really exciting to see with $75 million, which was not that much, partnerships with over 170 local aging and disability organizations across almost every state. Almost every one of the grantees partnered with their public health agencies in these efforts, and it broadened beyond COVID to include flu and shingles and RSV, with over 10,000 community events and over 800,000 vaccinations. And while maybe to some of you those numbers don't seem high, when you think about how high risk and how hard to reach some of these people are, I think it was an incredible partnership and force extender. Next slide. A second partnership I want to talk about is in one of the COVID supplements, there was funding to build the public health workforce. And I went to our secretary and I went to the White House and I said, the aging and disability networks are the public health workforce for older adults and people with disabilities. We don't need to go to public health systems that are stretched in so many ways and say, go become an expert on aging and disability. Let us hire, get this funding to bring in a person to build partnerships. And it was so exciting to get that funding and to see local disability and aging organizations bringing on staff. This was unfortunately one-time funding, whose sole role was to work with public health and build partnerships. Next slide. What was so exciting about this was, it facilitated collaboration and partnerships, and it was so incredible to see what happened. And even though this was one-time funding, when the funding ended, a number of state and local governments saw the value of continuing to fund those positions. And for example, in Virginia, they had funded through the Developmental Disabilities Council a person to work on inclusive emergency response. And then the Virginia Department of Emergency Management said, this is so important, we're going to keep funding this position. In building the pipeline of people who care about both aging and disability and public health, I just was speaking yesterday with someone who worked with a disability agency on emergency response and then went and got her master's in public health to really bring that expertise. So this is something that I hope these two examples are something maybe some of you experience, and that we build off these partnerships, even if that funding isn't there, even if the federal government isn't leading it, we need to keep these relationships warm. Next slide. So I think there are just so many opportunities to continue to grow these partnerships. We cannot forget the lessons that we learned in the pandemic, especially around partnerships. And there are just so many areas for collaboration. I think the inclusive emergency planning, we have got to be doing that. And I know many of you are probably picking up pieces that, once we could lean on the federal government and FEMA to be there as part of, and probably more and more is going to be, really focused on state and local government. And the age-friendly public health systems, thank you for what you're doing, and bring in disability too. And I think just right now in this moment in time, even on a day where this is incredibly important, I think getting out accurate information about vaccines and how to access them, and I know that has really been a major priority for many, many public health systems. The aging and disability networks can be partners there. Next slide. And one more, Karen. Okay, and just my takeaways are, just to say one more time, if you care about health equity, if you care about health disparities, if you care about serving underserved populations, then you need to care about aging and disability. It is just critical. The legal obligations are important, but it is the right thing to do. So hopefully you see this as really advancing your goals, but you also kind of need to do it. And then finally, just again, these partnerships with the aging and disability networks are so critical at a time when there are such stretched resources, so much responsibilities on the public health systems. Think of the aging and disability networks as a force multiplier and really, really continue that work. Next slide. So I will end there and right perfectly on time. I said I would leave 10 minutes for Q&As, so I'm happy to do that.
Thank you so much, Allison. This is so, so helpful. And I think, from our perspective at TIFA, with age-friendly public health, we haven't done enough to be inclusive of the disability community. And so I have a question about that in a moment, but there was a question about the reorganization at ACL and kind of where that stands. So I'm
Yeah.
sure everybody would like to hear about that first.
Yeah. So here is where things are. As people may know, I'll give that, as my teenagers would say, TLDR. In the announced reorganization, there was a proposal to completely eliminate the Administration for Community Living, spread the aging and disability programs across 3 separate agencies, and actually in the leaked OMB budget, eliminate nearly 20 critical aging and disability programs. I am an advocate no matter where I am, what role I'm in, and I will say advocacy makes a difference. And where things are now is because of incredible advocacy by the aging and disability networks. ACL will be staying together as a unit in aging and disability programs staying together. The proposal is to move it to the Administration for Children and Families. But at least not spread again across a lot of places. Again, because of advocacy, even in the president's budget, many of the proposed eliminated programs did not make it in the final president's budget, and the Senate and the House have rejected even the proposals that the president included in the budget. I will say there is a lawsuit, and it relates specifically to CDC and FDA and a couple specific agencies. And there is an injunction around those pieces at HHS. So while ACL, they are legally allowed to move forward with moving ACL into ACF, it has not, as a matter of reality, happened quite yet. Unfortunately, over half the staff at ACL has been terminated through rifts. So it is an incredibly difficult situation there, but we are a little bit in a limbo at the moment. But I will say it went from completely devastating to at least there is some preserving of programs, keeping aging and disability together, and at least some of the core staff at ACL.
Great. Thanks so much, Allison. Appreciate that answer. Does anyone else have a question for Allison? You have an amazing expert here, so I recommend taking advantage of it. Go ahead and just come off mute or raise your hand, Helen.
Good afternoon, and thank you so much. I want to start by just saying amen.
Thank you.
Yeah. I'm from Wisconsin, from the Department of Health Services, and we are really moving our age-friendly work forward, and our biggest tension is the name.
Yeah.
How do we get through that? Because when we talk about age-friendly, I don't know that the disability community sees themselves in that and go joyfully skipping to the work that is so relevant to them. And at this point, we're also wedded to the name.
Yeah.
So I'd take any
yeah. I mean, I will say
there.
that a similar thing has been coming up with multi-state agency
Sector,
plans on
yeah,
aging, or
sector
you know,
plan.
all the different names for aging plans. And some states have actually explicitly called them aging and disability, or you know, instead of age friendly, like inclusive communities. I'm going to go meet with folks in Connecticut where they have really started trying to bring together aging and disability in a really notable way. California has done the same. And, you know, I think it's a really important thing. I'm happy to offline with you, Helen. I wrote, you know, an article about kind of the commonalities, but having to respect the differences across the communities. It's like, who's the driver, who's welcome at the table? Is it a shared table? And I think, you know, being intentional about that. Are you inviting disability to be a part? Or is this really about inclusive communities, which I think it could be? I understand people are wedded to different language. And so, yeah, I think across the lifespan, I love some of these suggestions here: inclusivity, longevity, lifespan, yeah, all those things. But I think it's a really important question. And it is true that the disability community will not naturally see age friendly and think it's them, the same way that probably older adults do not see the word disability and think of themselves. So I do think it is so important, and happy to offline with you and would love to hear what you're doing. You have great disability partners in Wisconsin, particularly your DD Council's amazing.
I would love that. So yes,
Great.
thanks.
Yeah, we're thrilled with what Wisconsin is doing as well. Thank you, Helen, for the question. And I do kind of wonder if you know, is age friendly? Yeah, is age friendly the right term? We've had that question for a long time. But I mean, if you talk to AARP, which kind of they don't necessarily own the term age friendly. We're all using it now, but they will say if you make a community age friendly for one population, it's going to be good for everyone. And so that's one way to look at it. It doesn't solve the issue for sure, but it's certainly one way to look at it. Any
Yeah.
other questions or comment? Oh, sorry, Alison, I don't mean to cut you off.
Oh, yes, I agree. Probably, let me just say, we talk about the curb cut effect of disability. I mean, actually, we have stronger disability rights laws. Communities are accessible because of disability rights laws. When we talk about the curb cut effect, it's like, hey, that happened because of the ADA and people with physical disabilities, but look at it benefits everyone. And so, yeah, I do think the language is important. We just did through ASA something on the intersection of aging and disability, and I'll just say, coming from the gerontology world, and it does match a lot of the reaction from the disability world, this idea of healthy aging. And in some ways, there's ableism right in the middle of that. It's like, it's a failure if you know, start having disabilities. And it's like, no, that's a natural part of aging. And how do we talk about maybe aging well instead of healthy aging? So I think words do matter. And it's an important conversation to have, even if what we started 10 or 15 years ago, like times change, partnerships change. And I'm really would love to be part of a conversation on that.
Yeah, you absolutely will be. As we continue with these conversations, they're very, very important. And you know, we don't want for anyone to feel like they can't be part of the conversation because of how we're characterizing it. So really important. We are about at the end of our time. So Alison, thank you again. This has been fantastic. This session is being recorded, and we will send out the link to the recording as well as the slide deck to anyone who has registered. So feel free to pass those on. I am going to stop here and turn it back over to my colleague, Dr. Karan Phillips, to close us out.
Thank you, Megan. And again, thank you so much, Alison. I always learn something new from all these different talks that I've attended with you. So again, thank you so much. Our next training will be on October 16th at 3 p.m. Eastern Standard Time. You will be able to register for that under AFPHS.org under events. Our speaker will be from US Aging, talking about dementia friendly and the importance of dementia friendly work with the age-friendly ecosystem. And for those of you that are pursuing AFPHS champion designation, please make sure that you note that you attended this training by navigating to the website noted on the screen or using the QR code on the side to indicate that you were here and that you attended this session. If you're viewing this as a recording, please pause now to note that you have viewed this particular recording as part of your pursuit to become an AFPHS champion. As a reminder, AFPHS champions are our wonderful leaders that have viewed 6 or more of our trainings. And again, thank you all for attending today.
Thanks, everyone.
Thank
Hopefully we'll see you
you.
next month. Thanks, Allison. Take care, everyone.